So good day, dear colleagues. Today we'll have the next lecture from the psychiatry, and it will be regarding the affective disorders. Speaking about the affective disorders, we have to understand that we will talk about the emotions, disorders of emotions and specific features of them. First of all, it says that emotions, they are the responses in the form of subjectively tinctured feelings of an individual which reflect significance of an acting stimulus or a result of an act for him. It means that speaking about the emotions, we are talking about the subjective feelings of the person regarding some specific features of external or internal irritants. Speaking about them, we have to say that they have their own specific functions. These functions are the reflective function, the target function, information, enabling, regulatory, and reinforces the function. Speaking about the reflective function, it means that due to this function, we can understand what do we feel regarding this or that irritant. It means some of them can be pleasurable and desirable. Some of them will be negatively affected. It means that we can understand our feelings regarding something. Target function, it occurs when we understand that we want this or that. It means that if we will understand that these or that functions will be extremely desirable. And we can choose the target regarding these pleasurable emotions. Another thing that we have to say regarding the emotions, that they have their informational function. They give us ability to understand the information regarding the external or internal world. Enabling function, it occurs when we are scared or afraid of something. For example, we are scared to go on the height, or for example, we are scared to walk in the dark places or spaces. And in this case, the emotional component will disable these specific things. Regulatory function help us to regulate our behavior, our desires, our wishes, and other things in our world. And they reinforce the function. It means that due to them, we can do something more strongly and more desirably. Speaking about other functions of the emotions, we can say that they have the switching function. It means we can change the way when we will pay the attention on something. If we have something more pleasurable, more desirable, we will choose this object. For example, we have a movie for the evening and we are watching this movie, and for example, our colleague, our friend near us is watching another movie, and we see that our movie is not so interesting and his one is very interesting, so we can choose our attention to the another movie, and we will choose another one. Adaptive function help us to adapt to the different situations, and it help us also to understand what is better for us. Communicative function help us to analyze what do people feel, what do people want, and potentially we can prognose their reactions on specific behavior of us. The protective function help us to protect our life and our functioning, because only due to emotions we don't do things that are not preferable for us if you're talking about the long perspectives. Speaking about the stages of development of emotions, we can say that they have their specific stages. It means that they does not occur from the beginning. They occur after some time of living. The first stage is the stage of the newborn, and we know that on this stage there is the predominance of the instincts, and especially self-preservation instincts. It means that the child wants to satisfy the main needs, for example, to be in the warm place and to eat. Yeah, as a rule, we are talking about the mother's breast. And the second stage is the stage of the organic feelings. We know that on this stage, there is the processing of information from the extra and interoceptors and the emergence of unstable figurative representations of the reality to the experience of meeting a child. For example, we are talking about the satisfaction or dissatisfaction of main needs. We know on this stage people understand what is pleasant for them and what is not pleasant. And we know that all people, they go through all the stages of the development of the emotions. The stage 3, it occurs from 3 to 4 years till 12 years or 14 years, a stage when people have more difficult or more complicated emotions. It's stage of epicretic emotions and organic needs. We know that on this stage, people or children understand what do they want, how do they want, and they can prognose and they can organize their way of living. On the fourth stage, it's from 12 to 22 years old, a stage of mental self-expression or cortical emotions. What is specific on this stage? On this stage is specific that feature that people can control and can prognose what type of reaction they will have if they will do or not do this or that thing. Also, speaking about this stage, we can say that if people would not have this stage, all of people will use psychoactive substances, narcotics, alcohol, because they give extremely high feeling of pleasure. But we understand if you will use the psychoactive substances, potentially it can lead to the problems of social functioning, problems with the health, problems with all the spheres of the living. And it means that on this stage, for stage, people don't use psychoactive substances because they have these cortical emotions. It means they can prevent or they can prognose what is better to do to have better emotions in the future. Also, if you're talking about the components of emotional functioning, we can say that there are a few of them. For example, there is the intensity of strengths and depths of emotions, the basic background, positive or negative. All the emotions, they can be divided into two main groups. It's sthenic and asthenic emotions. Speaking about the sthenic emotions, we have to say that they increase the functioning of the organism. It means that they make our body to work better. It means that we can behave much better than until this emotion occur. Speaking about the asthenic emotions, we are talking about the reducing the vital function of the body emotions, and it means that they worsen the functioning. As a rule, if you're talking about the asthenic emotions, we are talking about the positive emotions. And as a rule, negative emotions, they are asthenic. But in some cases, it can be opposite. For example, if the person is living only in the good emotional states, for example, if only positive emotions are present, in this case, the person does not want to do anything to develop different things of the spheres of their life. And it means that positive emotion can be asthenic, and sometimes negative emotions can be sthenic. One of the best examples for me is the example when the student come to the class. For example, the student were studying a lot and the teacher puts negative mark to the student. And speaking about such type of interaction between the teacher and the student, for example, if the student will say that, okay, if you put me negative mark, if I knew everything, I will not teach anymore, I will not study anymore. And it means that in this case, the negative emotions will be asthenic. But if the student will say that I will prefer to study more, it means that in this case, it will be the example of asthenic negative emotion. Speaking about the emotions, we have to say that they are, or there are emotional states, or we can say that it is mood. As a rule, we are talking about the mood when the person have the long term, some specific level of mood. It can be positive or negative. Speaking about the emotional relations, we are talking about the specific attitude to some object or subjects. For example, we can like the ice cream, we can prefer having holidays in the forest, for example, or in the sea. And in this case, we can say that feelings, they can show the desirability of some specific type of behavior. And the emotional reactions, it affects, for example, we can be angry, we can be sad, we can be happy if we will have some specific things in our life. How can we classify the emotions? They can be classified in different specific features, but the first and the main thing that you have to know is what is affect. Speaking about the affect, we can say that it's special emotional state, which is a very strong short-term excitement or flash of emotions. For example, it can be fear, anger, rage, despair, and so forth. We know that they occurs extremely rapidly, and they are characterized by the sudden onset, short duration, and pronounced changes of consciousness, disturbance of violational control over the actions. And as a rule, we are talking about the changing in the work of internal organs and muscles. So affect, it's very strong, very short-term emotion that occurs extremely suddenly. As a rule, we are talking about two types of the effect, the physiological effect and pathological effect. What is physiological effect? Physiological effect, it arises in state which occurs very quickly. And as a rule, we are talking about the inability to control normally the behavior, but we can say that these people can have the disorders of consciousness, but in this case, it's only the nerving of the consciousness. And we know that in this case, also people have the inhibition of the intellectual activity. In the opposite side, the pathological effect is characterized by the full dimming of the consciousness and uncontrollable impulsive action, more aggressive and the destructive nature. It means when the person has the physiological effect, the ability to control the behavior is decreased, but still we can understand what are we doing. But if you're talking about the pathological effect, as a rule, people cannot control the behavior and cannot understand what is going on around because there are disorders of consciousness. Why are we talking about the physiological and pathological effect? It is known that people which commit different negative things, for example, if they destroyed something, if they killed something, in the state of the pathological effect, they will not go to the prison. Yeah, because they could not control this type of behavior. Disorders of emotions, they are divided into two main groups, qualitative and quantitative. Quantitative disorders of emotions is hyperthymia and hypothymia. Speaking about the hyperthymia, we have to say that's painful emotional increase or increasing of the emotions. In this category, we have two main ones. It's mania and depression. Speaking about the mania, we can say that it's persistent, painful mood enhancement. And speaking about the depression, it's the opposite to the mania, and it's persistent, painful, depressed mood. Mania can be divided into two main types. It can be the euphoric and moric, or euphoria and moria. Speaking about the aphoria, we have to say that two main components have to be present. First of all, it's mood enhancement. And the second one, it's motor retardation. It means that the person just feel extremely positive emotions without doing anything. And speaking about the moria, we are talking about mood enhancement, persistent, painful, and plus motor excitation and plus silliness. It means that people move a lot and these movements or their behavior is quite stupid, silly. For example, people can talk with other people like idiots. They show not all the best of their behavior, and it's like specific states that can be met in people, for example, who have the organic injuries of the frontal lobe of the brain, or sometimes it can occur in people who have the intoxication of the psychoactive substances of the stimulative type, or sometimes even they can be present in people who have the bipolar disorder in the manic state. We'll talk about the mania and depression a little later, and also we have to say that the second group of the emotional quantitative emotional disorders is hypothymia. We have to say that it's painful emotional reduction. In this group, we have some of the disorders. First of all, it's apathy. Apathy is characterized by the lack of the higher emotions. It means that people in this state that they cannot enjoy of the external irritants, they are not interested in doing different things, and everything is extremely dull and flat. Emotional stupidity or emotional impoverishment. We are talking about the absence of the higher and the lower emotions. Speaking about this state of the emotional disorder, we have to say that people, as a rule, don't feel like the different fluctuations of the emotions. As a rule, the emotional fluctuations is very low. It means for feeling specific emotions, they have to have stronger irritants than previously. Apathy is characterized for people who have the depressive disorder. Emotional stupidity, for example, it can be in people who have schizophrenic disorder. Emotional monotony is the weakening of the expression of the emotional reactions. It means that people have inability to show their emotions. As a rule, we can see this emotional disorder when we will look on the face of the person. As a rule, there is no mimics, there is no changing of the gestures, and people speech is very monotonic. Emotional coldness, it's state that is characterized by the indifference to their loved ones. It means that people say that they even does not care about problems of their children, of their relatives. They does not care about their friends and other people who were previously close to them. Emotional monotony and emotional coldness, it states that can be present in people who have schizophrenic disorder, and for example, emotional coldness can be in people who have depressive disorder. As a rule, people who have depressive disorders, they have feeling of self-approach because they say that I'm a very bad person because I even don't feel anything regarding my children, and I am not satisfied with it. I don't care that my son fell down and the head is aching, or for example, somebody broke the foot and I don't care about it. It means that people feel that it's not good, logically feel or understand that it's not okay, don't feel emotion. And emotional brutalization, we are talking about this case if the person have the loss of thin differentiated emotions. When people lose the tact, the empathy, and other emotional normal reactions. As a rule, we are talking about this emotional brutalization in people who use psychoactive substances, who have organic injuries of the brain, Another group of the emotional violations, it's paradigmic disorders or quality emotional disorders. In this group, we have some, for example, ambivalence, dysphoria, pathological anxiety, dysthymia, and the inadequacy of the emotions. What is ambivalence? We are talking about the ambivalence in the case if the person have two opposite emotional reactions or feelings to some specific objects or irritants. This state can be compared with the state when we have the loved one person, we have very good relations, but in some cases, if the person behave not very good, if we are extremely anxious regarding some behavior of the patient, in this case, we understand that we love this person and we want to kill this person. It means that we hate and we love at the same time. But if you're talking about this ambivalence, people who, for example, suffer from schizophrenia, they can have these ambivalent emotions towards very lot of things. They can say that I like coffee and I hate coffee. I enjoy this music, but it's awful. It means that they have like two opposite things at the same time. The inadequacy of the emotions, it is characterized by the inadequate reaction to the irritants or inadequate response to the occasion. We are talking about this case if people, for example, can laugh in the case when it's very sad, or if the person will cry in the case when it's extremely good situation. But it's not the tears of the pleasure, but it will be tears of negative emotions. One of the example is a few years ago, one of our students, he were the student from the Poland. He came to me for the consultation and he told, for example, that he had a girlfriend. She were also the foreign student, and he gave her flowers. And when she saw the flowers, she said, "Thank you, I'm extremely happy," and she bite him in the face. It means that she were behaving very specific, inadequate way. So she had inadequate emotional reaction. Dysthymia, it's the state when the person have chronic decreased mood, and as a rule, we are talking about the dysthymic disorder when the person is unable to feel normal positive emotions. Dysthymic state is characterized by the low developed negative emotions. And we are talking about the dysthymia in the case if this emotional decreasing is not so strong to say that it is depressive disorder. Dysphoric or dysphoria, it's state that occurs extremely quickly. The person does not want this state, and as a rule, it cannot be controlled. For example, the person can be normal, and in the second he become aggressive, he become the person who have quarrels with everybody, he feel like he's very explosive. As a rule, we are talking about the dysphoria in the people who have organic injuries of the brain. It can be present in people who suffer from the epileptic disease, and it can be one of the equivalents of the epilepsy. Speaking about the inadequacy of the emotions, it is characterized, it is typical for people who have the schizophrenic disorder. As ambivalence, it's also present in this kind of people. And dysthymia, it can be in people who have mild depressive disorders, or it can be just like a separate state. And the pathological anxiety, we are talking about this state when the person have the emotional painful long-term experience of the inner discomfort of uncertain content. It means if the person just feels that he or she cannot relax, cannot feel normally, and all the time he feel like something is going on inside. So it's pathological anxiety. So we are talking about these states when people have the depressive disorder, depressive anxiety disorders. In some cases, it can be in people who have the schizophrenic disorders. So, speaking about the disorders of emotions, we have to say that there are three main syndromes, affective syndromes. It's depressive, it's manic, and it is dysphoric. What is depressive syndrome? Depressive syndrome is characterized by the presence of the three main symptoms. First of all, it's decreased mood, because depressive syndrome is the disorder of emotions. So emotions, they are decreased. Another feature, it's ideatory component or thinking component. It decreases in speed. So the thinking is slowed down. As a rule, these people, they speak slowly. They feel difficulties to understand what other people are talking to them. They cannot count, they cannot memorize things. It means that every mental process in their brain, it's slowed down, and it's very difficult for these people to understand what is going on around. And the third component is movements, or relational component. So people move slowly, they feel difficulties with their movements, with their behavior. So these three main symptoms, they are included in the classical depressive triad, or triad of Kraepelin. Also, speaking about the depressive syndrome, as a rule, it has a lot of other symptoms, like inability to feel positive emotions, it's sleep disorders, appetite disorders. Sometimes people have the inability to perform routine activities, for example, washing, cleaning, preparing food. We know that most of people who have the depressive disorder, they have the specific complex of sympathetic tonic symptoms. We name these sympathetic tonic symptoms as Protopopov triad. It's mydriasis, it's tachycardia, and constipation. So if we are talking with the patient and we are not sure is it depression or maybe it's some other state, for example, the beginning of the psychosis, in this case, we are talking about this Protopopov triad that sometimes can help us to understand that it is psychotic, not psychotic disorder, but it's mood disorder. So if we see the mydriasis, tachycardia, and constipation, we can say that potentially it's depressive disorder. What is depressive syndrome, and what are the clinical variants of the depression? There are a lot of different types of the depressive syndrome, and we can say that, for example, the anesthetic depression is characterized by the inability to feel emotions. So people who have this type of depressive syndrome, they say that they just don't feel anything. The depressive syndrome can be associated with the phobias. For example, people are scared that something will happen very soon, that their relatives can die from some specific external situations. They can be scared to go outside from their house because they can feel that they cannot help themselves. With anxiety, it's state when it's characterized by the presence of the developed anxiety. But if you're talking about the presence of the anxiety that is developed so much as the depressive syndrome, we are not talking about the classical depressive syndrome. We are talking about the depressive anxiety syndrome. But most of the patients who have the depressive syndrome, as a rule, they have anxiety, but it's not developed so much as depression. It means when the influence of the symptom is not developed so much as another one, In this case, we are talking about the classical depressive syndrome. Agitated depression. In this case, people cannot find the place where they can feel normally. So they have to move, they have to do different things. It means that they have to move all the time. It's like the feeling of internal irritability and ability to sit still. Depressive stupor. People with this type of depression, they sit and look into one point and they, as a rule, don't move. Yeah, they are like just bodies. Psychotic depression is characterized by the presence of the delusions and hallucinations. The statistics says that nearly 30% of people with severe depression, they have the hallucinations. Guys, 30%, it means every third person with the severe depression. And speaking about the delusions, they are also extremely often present in this group of the patients. Delusions, as a rule, it's delusions that make the person feel worse. For example, these people say that they have the disease that cannot be treated, that nobody will help them, that they have to be burnt in the fire because they did a lot of negative things previously. Also, these people say that the future does not have any positive moments and it's better to die than to live in this world because there is no opportunity to be normal. The mask depression, it's a depression that is not classical and not typical. Why are we talking about not classical and typical? Because if the person has mask depression, as a rule, in this state, people have symptoms that cannot be associated with the depression. For example, they can have the heartache, they can have the headache that is not that is not treated, or when we give the medication that will have to reduce the symptoms of this disorder, they does not help. In this case, we are talking about the mask depression. Or if the person have the problems with gastrointestinal systems or genitourinary system. And subdepression, it's symptoms of depression that are not developed very much. Another syndrome that is present in the mood disorders, it's the manic syndrome. Speaking about the manic syndrome, we have to say that three main symptoms that were typically present in the depressive patient, they are opposite in this group of the patients. First of all, it's increased mood or painfully elevated mood. People feel that they are happy without any specific reason, without any specific condition. These people, they have the increasing of their thoughts, so they think more quickly. And how do we know that they think more quickly? They are talking extremely quick, they are having a lot of association, and in some cases they have the specific delusions of the grandiosity. And the third thing is the motor excitation or hyperbulia. These people, they are moving a lot, they want to do a lot of things, they feel a lot of energy, they feel that they are not they can do a lot of things, and it will not lead to the decreasing of their energy. Also, people with manic syndrome, they can have the increasing of their instincts, for example, food sex. They can be hypersexual. One of my patients, he told that, doctor, you don't understand, but if I have erection, it can be 24 hours. I can have sexual relations, like I have a thing like I can do it for days. So I become extremely hypersexual. Some of the patients who have the mania, they can become such hypersexual that they have, for example, there were one of people who worked in the medical university, in our university, she had the sexual relations with more than 10 guys in one day. It means that they want to have sex quite a lot. Also, these people, they start wasting money. They typically become more conflict and more like easily started. It means that they can start conflicts very easily, and as a rule, these people have conflicts which lead to the hospitalization to the mental hospital. Also, people with typical manic disorders, they have the shortening of the duration of sleep. They can sleep for a few hours a day, for example, 2-3 hours, and they say that I feel okay and I don't need more sleep. We have different types of the manic syndrome or different variants of the manic syndrome. And for example, it can be the mania with euphoria. As you remember, it's the state when the person just feels positive emotions and doesn't want to move. It's just pleasure without doing anything. A mania with moria, it's state when the person moves a lot and have stupid, foolish behavior. With irritability, as a rule, we have like two types of the manic patients in the mental hospital. It's mania with irritability, because these people, they have a lot of conflicts, and as a rule, these conflicts, they're extremely developed. Can you imagine that you believe that you are extremely smart, extremely beautiful, extremely rich, and somebody is telling you what to do and how to do? And in the same state, you are extremely irritable. It means that you behave like a god. Yeah, you want to destroy everything, and it leads to the hospitalization. As a rule, it leads to the hospitalization to the mental hospital. A few years ago, one of our students of the fourth course, fourth year student of the medical faculty, during the manic state, he had conflict with the security, and he destroyed the windows. He had like the physical battle with this guy, and he was hospitalized to our mental hospital. Unproductive mania, it's mania when people start doing things when they, as a rule, don't finish any of them. How does it look like? It looked like one of my patients told me that, doctor, you don't understand. I don't want to sleep. I can sleep for 2 or 3 hours a day, and it's night. Yeah, it's 2 hours in the night, and I understood that I want to change where my furniture stands, and I want to change it. I'm taking the sofa and I'm moving it in the middle of the room. Then I understood that I want to wash my shoes. I took all my shoes from everywhere, and every flat is in the shoes, in the furniture. I started to repair some things that I wanted to do for many times. Then I understood that I wanted to start the business, and I'm choosing what to do. And it means that there is a mess in every sphere of the life, because this mania is unproductive, but still people want to do more and more, and nothing ends normally. And the second group of the patients who are hospitalized in the mental hospital, except the irritable type of the mania, it's the mania with the psychotic symptoms. Mania with the psychotic symptoms, it's mania with the presence of the delusions and hallucinations. So people with this type of mania, they can hear voices, they can see some different things. And as a rule, these people say that they're extremely smart, extremely famous, that they can know how to treat people without medications. They have specific energies. They can feel the energy from others people. They can predict some negative situations and something like it. And as a rule, these negative or pathological thoughts lead to the hospitalization of the patients to the mental hospital. And the third syndrome, it's dysphoric syndrome or dysphoria. Speaking about the dysphoria, we are talking about the irritability, maliciousness, dissatisfaction accompanied by the aggression and the destructive actions. So dysphoria or dysphoric reaction and dysphoric background. Dysphoric reaction, it means the small irritant lead to extremely developed reaction, negative reaction. For example, a few years ago, one of our teachers from our department took the students to the psychiatric department. And there were a patient who were talking with students billion of times, and this patient were normal every time. But in the middle of the conversation, this patient took the chair and started to be aggressive toward the students without any specific reason. This patient was treated from the epileptic disorders of personality in the psychiatric department, and he had the dysphoria. Yeah, it were the dysphoric background. It means that he were irritable without any specific reasons. If we are talking about disorders of mood, we have to understand what is mood and what is affect. Speaking about the mood, it's sustained emotional attitude, typically garnered through the self-report affect. The emotional state is conveyed, relates more to others' perception of emotional state and responsiveness. And speaking about the mood disorders, we are talking about the conditions where the mood is primary and the predominant problem. So, speaking about the mood disorders, we are talking about this specific state. First thing that we will talk about of our disorder is major depressive disorder. We know that in our days, the depression is now, the last statistics say that it's on the third place in the world of the most urgent health problems. And the World Health Organization says that till 2050, it will be #1 in the whole world by the disabilities of the people in the whole world. It means it will be more developed than people who have cardiovascular diseases and oncopathology. So it's quite a problematic scene. We know that the average onset of the depressive disorder is between 20 and 40 years. And we know that the lifetime prevalence is between the 16.5 of the population from 10 till 25. It is more common between women than in men. An estimated 120 million people worldwide suffer from the depressive disorder. We know that there are specific demographic risk factors. It can be the age. We know that initial onset is the most common among the young adults. The social economic status, we know that people who are in the lower social ladder, they are at the greater risks than those who are in the better off. It is known that, speaking about the etiology of all the mental diseases, we know that it's multi-factor etiology. We say that it's psychosocial reasons of the mood disorders also is the main reason of it. So people who are on the lower social ladder, they have more stresses and they have less ability to be treated by normal doctors with other somatic diseases. And typically these frustrating things lead to the greater risk of the depression. We know that marital status also have influence on the development of the depressions. People who are separated or divorced have higher rates than married or never married people. It's interesting because people who have been married and divorced, or who have never been married, they are more happy than people who were in this situation. And for example, if we look on the statistics, people who were divorced, for example, men who were divorced, they have the increase of the quality of life. The world statistic show us these things. We know that some diseases can be concomitant with depressive disorder. First of all, it's endocrinological diseases. So from 20 to 30% of people who have them will have the depression. The diabetes up to 10%, central viral infections near 10%, neoplasms, it means the oncopathology from 20 to 40%, cardiovascular diseases 15 to 25, kidney 20, hepatic up to 15, blood serum diseases up to 20, and number one is central nervous system diseases. We know that most of patients who have strokes, people who have neoplasms of the brain, they will have the depressive disorder, more than half of all the patients. And the chronic pain is also extremely often have the depressive disease. People with chronic pain have the depressive disease. Near every second one will have it. We know that some medications that are used by people can lead to the depressive disorders. It's hypertension drugs, calcium channel antagonists, corticosteroids, gestogens, anti-Parkinson drugs, psychotropic drugs, anti-neoplasmatic drugs. Some organic causes of the depression. It can be the neurological ones, for example, stroke, Alzheimer's disease, Parkinson's, Huntington's disease, multiple sclerosis, epileptic disease, tumors. Endocrine pathology can also lead metabolic, infective use of specific drugs, and neoplasm, as we told before. Speaking about the specific criteria of the depressive disorders, we have to say that there are two main classifications. There is American Diagnostical and Statistical Manual, and there is the ICD, International Classification of the Diseases. DSM is used in the USA, and ICD is used in the Europe. So, speaking about the DSM, as for me, it's more interesting. And the main symptoms, they are 5 or more of the following symptoms that have been present during the same 2-week period and represent a change from the previous functioning. And at least one of the next symptoms, or even more, must be present. You have to have the depressed mood or loss of interest or pleasure. Speaking about the depressed mood, we are talking about specific decreased mood state that is present nearly every day, most of the day, and it leads to the decreasing of the normal functioning of the person. Or the second symptom is loss of the interest of the pleasure. It means the person is not able to feel quite a lot positive emotion as it were before. For example, previously you enjoyed listening music, watching movies, communicating with people, going to sport, but now you feel like you're not interested in it, and these activities, they does not lead to the presence of the positive emotions. Significant weight loss when not dieting or weight gain. We are talking about the symptom when we can see the change in 5% of the body weight in a month, or decrease or increase near of the appetite nearly every day. Speaking about the children, we consider failure to make the expected weight gain. So we have to understand that children, they can increase their weight because they are growing up. Insomnia or hypersomnia every day. Psychomotor agitation or retardation, when people can be with this agitated depressive syndrome, or when they will be retarded. As a rule, people with the depression, they are very slowed down. They have feeling that it's very difficult for them to move, and they have problems with performing routine activities. Fatigue or loss of energy nearly every day. These people say that they have feeling that there is no energy at all and they cannot do any activities because they cannot. It's very difficult for them. Feeling of worthlessness or excessive or inappropriate guilt, which may be even in some cases delusional. And these symptoms have to be present nearly every day, not merely self-report or guilt about being thick. It means that if the person says that I am extremely bad guy or bad mother because I am ill, it's not this symptom. Diminished ability to think or concentrate. Sometimes this symptom can be present so much that people even cannot read books, watch movies. In some cases, it can be developed so much that they even cannot communicate over the phone or face to face. So they cannot understand what is going on around, and they does not want to do this activity. Recurrent thoughts of death is also one of the main symptoms that are present in most of the patients with the mild depressive disorder. Or in some cases, we have to talk about the suicidal attempt or specific suicidal plan to commit suicide. The statistics say that nearly 80% of people who have moderate and severe depression, they have the suicidal thoughts. And speaking with these people, we can say that these people say that maybe I don't want to die, but I don't want to suffer. And in my case, it's better to kill myself because I don't feel normally at all. Speaking about the DSM criteria, we have to say that the symptom does not meet the criteria for the mixed episode. Mixed episode when there are mixed symptoms of manic and depressive state connected together. And the symptoms cause clinically significant distress or impairment in the social, occupational, or other important areas of the functioning. The symptoms are not due to the direct physiological effect or a substance or a general medical condition. For example, if the person used psychoactive substances like sedatives or psychostimulants, which lead to the depressive disorder, in this case, we are not talking about the classical mild depressive disorder. We are talking about the depression caused by the use of something. Or if there is somatic disease that lead to the depressive disorder, we are talking about the somatic depression or secondary depression. The symptoms are not better accounted for a bereavement. For example, after the loss of the loved one, the symptoms persist for longer than 2 months or are characterized by the marked functional impairment, morbid preoccupation with the worthlessness, suicidal ideation, psychotic symptoms, or psychomotor retardation. What are the main clusters of the symptoms that can be met in people who suffer from the depression? It's vegetative, it's physical, impulse control, behavioral, and cognitive. Speaking about the vegetative symptoms, we can say that these people can have such symptoms as headache, like globus hystericus. It's like when people say that I cannot even eat because there is something in my neck. It can be palpitation, it can be feeling of ants under the skin and something like it. It can be increasing or decreasing in the blood pressure. Physical or somatic symptoms, it's symptoms that typically present in such people. It can be like muscle aches, it can be constipation, and others. Impulse control, people in some cases can be very irritable, or in some cases they cannot start routine activities. In some cases, people who have the depressive disorders, they even don't wash themselves, they even cannot stand from their bed. Behavioral, people as a rule, they change their behavior, they stop communicating with people, they stop doing things that they were doing before, and it lead to the great social problem. And the cognitive, we were talking about them when people, for example, cannot even read the book, communicate with other people because they cannot understand what is going on during the conversation. Speaking about them, diagnosing the depression, we can say that there are some specific things that can help us to do it. First of all, let's say that when we want to diagnose any specific mental disorder, it's seen that is that can be made only due to our conversation. So if we communicate with the patient, we ask specific questions, and in some cases, we can look on the appearance of the patient. Typical depressive patients have the decreased emotional, mimical, facial expression. Voice and statements are also typical in these people. They have the low voice, and this voice does not have the fluctuations. Movements and body position. People, they move very slowly. Their body position is like they are very retarded, and it can help us to diagnose the depressive disorder. Speaking about the classical or typical complaints of this group of people, they say that they have a feeling of the internal tension, restlessness, anxiety. They say they does not want to communicate with their colleagues, friends, and sometimes even family members. They have problems with sleeping, and one of the main symptoms is early waking up. What is early waking up? For example, the person could not get asleep in the night. For example, they laid in the bed in the 10 o'clock and go to sleep at 4 in the night. And for example, the job is in the 8 o'clock and 6:30, it's the alarm. And the person can wake up at 5 o'clock and cannot sleep again. And the person can say that I want to sleep, but I cannot get a sleep again. And this early waking up is one of the main symptoms of the depression. Bad frame of mind in the morning. So people feel worse in the morning than in the evening. In the evening, they feel better. Most of people, they have the loss of appetite, but in some cases, the appetite can be increased. And some people can say that they lost their weight. Near 2 weeks ago, I had a patient and she lost near 30 kilograms during 2 months because she had the depressive disorder. So sometimes the weight can be decreased extremely quickly. Loss of appetite, many somatic complaints can also be present in this category of people. People say that they have headache, muscle ache, they have bad feelings in the stomach. Sometimes they have feeling that their heart is not beating normally. They have pulsing in the vessels of their body and something like it. Constant feeling of being tired. These people say that they all the time is extremely tired and nothing can help their condition. Reluctance to everyday work. So they cannot prepare food, they cannot wash themselves, they cannot change their clothes, and as a rule, these people have specific complaints. For example, they say that nothing makes me happy, I don't care about anything, feeling guilty regarding different things, lack of life satisfaction, aversion to life, feeling hopelessness, thoughts of death. It's also main complaints of these people. These people say that I don't care, is it sunny or rainy weather? I don't notice it. I don't care if something make me some present. It's nothing for me. It doesn't matter what I will watch, the TV program with idiots or very interesting movie, and everything is like the same for me. Also, these people say that they have the worst memory, difficulties on paying attention, and as we told before, they have problems with reading and, for example, watching TV. We know that near 50% of the cases, they are not diagnosed. And first of all, these people come to the physicians, like general practitioners, with the specific complaints. And these complaints, as a rule, they are somatic. And we know that every specific specialist, every specific doctor is looking for his own symptoms. It means if you will come to the cardiologist will ask the symptoms that typically is present in the cardiological patients. If you will go to the gastroenterologist, the questions will be specific to this type of the doctor. And for example, if you will go to the urologist or gynecologist, also the symptoms will be specific. And speaking about the typical depressive patients, they have very big amount of the symptoms. It means that every doctor can find his own symptoms. And for example, if the person says that I have the menstrual disorders, I have hypersexuality, I have other symptoms, the gynecologist will say, okay, you are my patients and let's start treating you. And we know that in many cases, these people, they have the depressive disorder, which is not diagnosed. Existing options, it means that people is not thinking about the potential ability that the person can have the depressive disorder. And another problem is very short time consultation. Most of the doctors, they have the time limitations, which reduce the ability to diagnose the depressive disorder. If you look on the patient side, we can say that the patient typically is concentrated on the somatic disorders. We know that nobody wants to be mentally ill, and it's not like good to have mental disease. So people, as a rule, having complaints only like somatic types. Difficulties in recognizing the depressive symptoms to people who does not have knowledge regarding it. People, as a rule, who have the depressive disorder, they have somatic symptoms, as we told before, and in most of the cases, people pay more attention on these somatic symptoms than on other symptoms, and they are blaming specific symptoms on the depressive disorder. Sorry, they are thinking that they have negative mood because they have other somatic disorders, and they blaming on the depressive symptoms on the circumstances regarding, for example, I have decreased mood because I have a stomach ache during the last 2 weeks, and like it can be understandable. Speaking about the major depressive disorder, we can say that there are few types. It's major depressive disorder, depressive episode, and recurrent depressive disorder. We are talking about the depressive episode in the case if the person have only one episode or the first episode of the depression. We know that a lot of patients who have the depressive disorder, they can have the mood congruent delusions. For example, delusions of guilt or sinfulness, worthlessness, poverty, failure, persecution, and terminal somatic illnesses. It is caused by the thing that people have a lot of somatic complaints, people have negative thinking, people have negative interpretation of the future and the past, and it leads to this specific type of delusions. A typical clinical picture of the depressions can look like it. For example, the pain masks. It can be tension headaches, joint pain, neuralgias, vegetative and psychosomatic masks, pseudoangina pectoris, when people cannot breathe normally and they feel like that they cannot breathe because of their heart. Motoric impairment of gastrointestinal system, spastic states of bile ducts, restless legs syndrome, skin itch, pseudo-anorexia, or loss of weight. So, atypical clinical pictures of the depression. We know that people who have depressive disorders, they have the impairment of the biological rhythm. They have the disorders of sleep. In some cases, they can have the sleep insomnia. It means that they feel difficulties sleeping. They have the decreased amount of sleep, or in some cases, they can be very sleepy. They can sleep many, many hours. Psychopathological masks, for example, they can be agitated. they can feel the chronic acute anxiety, and they can have the compulsions, behavioral masks, and periodical alcohol abuse and periodical drug abuse. We know that quite a lot of people who are using the psychoactive substances, they are used on the secondary because they want to reduce, the patients who are using them, they want to reduce the symptoms of specific mental diseases. We know that people, for example, with schizophrenia, with bipolar disorder, in the depressive state, that they use quite a lot psychoactive substances. The second type of the depressive disorder, it's recurrent depressive disorder, or if we will say simple way, it's another episode of the depression if you know that the patient had previously the depressive episodes. So we are talking about this state in the case if the person has at least one previous episode, mild, moderate, or severe, lasting minimum of 2 weeks and represented from the current episode by at least 2 months. So it's like another mild depressive disorder. We know that there are two types of depression. There is endogenic. It means that there is no specific reasons that lead to the depression, and there is exogenic. Speaking about the endogenic depression, it just occurs and that's all. Exogenic, it's caused by the external stimulus. For example, if something negative happened in your life and your reaction of your mental state is depression. If the person had the exogenic depressive disorder 2 times, it means that if the person will have 3 times another one negative external irritant, potentially this person will have the internal or endogenous depressive disorder. So people change their type of normal living. Why are we talking about it? We are talking about it because the person has to prevent this recurrent continuous episodes of the depression. Another thing that you have to know very well is mania. What is mania, or what is manic episode? We know that there are 3 degrees of severity, and they are specified here, sharing the common underlying characteristics of the elevated mood and the increase in the quantity and speed of physical and mental activity. All the subdivisions of this category should be used only for a single manic episode. If previous or subsequent affect disorders or episodes, depressive, manic, or hypomanic, the disorder should be coded under the bipolar affective disorder. What does it mean? It means if the person have the first mood disorder in his life, and it's, for example, manic, we are talking about the manic episode. If it's second manic episode, or the manic episode occurred after the previous depression, we are talking about the bipolar disorder. So what is manic episode? We know that most commonly it occurs between the age of 15 and 30 years, but most of the patients have it from 15 to 20 years. We know that in some cases this manic episode can occur even in the early childhood, and in some cases it can be in the 70s or 80s. Speaking about the manic state, we know that there are hypomania and mania. What is hypomania? We are talking about the state when the mood is not and behavior is not disordered extremely. Persistent mild elevation of mood, increased energy and activity, and usually marked feelings of well-being and both physical and mental efficiency. Increased sociability, talkativeness, over familiarity, increased sexual energy, and the decreased need for sleep, and often present but not to the extent that they lead to severe disruption of work or result in social rejection. Most of people who have the hypomanic episode, they say that it's the best state in their life because everything extremely good. They have increased mood, increased activity, a lot of energy. They are very certain about themselves, that they know that they are very well in doing a lot of things. And these hypomanic symptoms, typically they does not lead to the social disorders and problems with the life of these people. And these people are enjoying being in this state. Most of patients who have the hypomanic or manic episodes, they, even when they are normal, they say that they are not normal because they want to be in this state. As we were talking previously, most of patients who are hospitalized in the mental hospital, they have the mania with the psychotic symptoms. This mania is characterized by the inflated self-esteem and grandiose ideas, which may be developed into the delusional. Irritability and suspiciousness may develop into delusions of persecution. In severe cases, the grandiose or religious delusions or identity role may be prominent. Flights of ideas and pressure of speech may result in the individual becoming incomprehensible. What is flight of ideas? When we were talking about the three main symptoms of the manic syndrome, we were talking about the increasing of speed of thinking. We know that the person can think more quickly than can pronounce the words and pronounce the thoughts. In the case if the thinking is developed so quickly that the person cannot pronounce it, cannot speak so quickly, in this case the thought can go further and the person cannot speak so quickly. And in this case the thought stops because person didn't pronounce it, and the another thought comes to the head, and the person were talking about one thought, didn't finish, and are starting to talk about another one. In this case, we are talking about the flight of ideas. So severe and sustained physical activity and excitement may result in the aggression or violence. Neglect of eating, drinking, and personal hygiene may result in the dangerous states of dehydration and self-neglect. We know that a lot of patients, they can have the mood congruent delusions. It's grandiose delusions, great wealth delusions, extraordinary abilities, and the power. We know that nearly 75% of all the patients with the mania, they will have the delusions. We know that there are some specific somatic and organic factors that may lead to the development of the mania. We know that people who are using these pharmacological medications can have the manic disorder. It's corticosteroids, it's L-DOPA, bromocriptine, cocaine, antidepressants. Influenza, infections of central nervous system, AIDS, syphilis can also lead to this state. Hormonal disorders like hyperthyroidism, Cushing syndrome, postpartum period can also lead to the manic syndrome. Connective tissue diseases like systemic lupus erythematosus. Neurological, like multiple sclerosis, Huntington's disease, Wilson's disease, head injuries, epilepsy, brain tumor, strokes, and migraine can lead to the development of the manic states. And the last part of this lecture will be regarding the bipolar disorder. We know that bipolar disorder, it occurs from 3 to 5% in the general population. Some statistics say that it can occur even to 15% if you're talking about the symptoms of bipolar sphere. We know that there are no significant differences between the racial groups and the prevalence in these disorders. The lifetime prevalence of bipolar 1, it's like classical big bipolar disorder, is from 0.4 to 1.6%. And bipolar 2, it's from 0.5, near 0.5 of the population. Completed suicide occurs in the 10-15% of the individuals with the bipolar disorder. Bipolar 1 disorder is characterized by the presence of one or more manic episodes or mixed episodes. Often the individuals have also had one or more mild depressive episodes. And if you're talking about the bipolar 2, there is one or more mild depressive disorders that accompanied by at least one of hypomanic episodes. It means that bipolar 1 is classical big bipolar disease. It means that there are specific big manias, quite strong manias, and deep depressions. Bipolar 2 is like small mania, can be small depression. We know that untreated patients with bipolar 1 disorders typically have from 8 to 10 episodes of mania and depression in their lifetime. We know that treatment, it reduces the ability that the person will have the other symptoms of bipolar disorders. There are different bipolar subtypes. For example, it's cyclothymia. We are talking about the presence of low-developed, low-grade cycling of mood. For example, it's small depressions and small manias. What do we have to do with the patient who have bipolar disorder? First of all, it's education. We have to cooperate between the patient and the practitioner and their relatives. We have to inform the patient about the diagnosis, about the prognosis of it, about the treatment options, because we know that there are, for example, generic drugs. We know that in some cases it's better not to take medications. So we have to explain the patient what is the potential duration and potential side effects of the treatment. And the patient have to choose what is better to do or not to do. We have to talk also with the family members, and we have to inform them about the depression and mania. We have to explain them what does it mean. We have to explain that the treatment can be effective and there are a lot of options. We have to understand, to explain what is the aim of the treatment and what is the risk of the recurrence. Risk of the recurrence, we know that, for example, it's 50% after the one episode and 70% after the two episodes. And if the person had 3 episodes, it's nearly 90%. They should be sensitive to early symptoms of recurrence and provide the care as quickly as possible. It means in some cases, if the person have the bipolar disorder, we can stop it very quickly when the symptoms only start to occur. And the relatives and the patient have to be very sensitive and very attentive to this, to the occurrence of these symptoms. Also, we have to explain to the patients and to the relatives that the suicide can occur in this category of the patients, and we have to explain that the symptoms of the disease can be treated and the person does not have to be in the low mood and to do things that potentially can lead to the suicidal attempts. How do we treat the mood disorders? First of all, we have to understand what are the main treatment objectives. It's the main thing that we have to do is the symptoms of remission, acute phase, and their restoration of the psychosocial function in acute and continuous phases, prevention of the relapses, and the prevention of the recurrence of the new episodes in the patient with recurrent depressions. It's in the phase when the person does not have the symptoms. We have like 3 main types of the treatment, and one treatment can be used in the situations when the previous 2 types cannot be used. First of all, it's medications. As a rule, we have to use the normotimic medications or normalizers of mood. In this group, we have anti-epileptic medications, some antipsychotics, lithium, and potentially that's all. Another thing that is used is psychotherapy. The best way is the combination of the medication and psychotherapy. And we also have one of the ways of the treatment of the bipolar disorder and sometimes recurrent depressive and mild depressive disorders, it's electroconvulsive therapy. It's method that is used and have specific situations where it can be used. For example, when the patient cannot take the medication, or if the medication does not work, or if the patient have the contraindication toward the medications. So depression during the bipolar disorder is typically not treated by the antidepressants, by normotinics. Sometimes they can be given only in the severe depression, and it has to be you have to be very carefully to do it. The most effective medication for the treatment of the bipolar disorder is lithium. On this picture, you can see the typical patient with the bipolar disorder. This is the last slide, and I hope that you will not forget the material.